Okay, Bismillah ar-Rahman ar-Rahim. Good evening, good afternoon, and good morning, everyone around the globe. My name is Mohammed Karrar. I am the Secretary General of Sudanese Association of Pediatricians in Kingdom of Saudi Arabia. I am here to welcome you all on behalf of SAP KSA. Our distinguished guests from USA, they will draw a light on important topic today that's affecting different areas of the world, importantly in Sudan. I also would like to announce and wish a good start for the academic office and activities of the academic office. We have Dr. Fathiya Sheikh and Dr. Taha Ibrahim. They will moderate this session. I'm welcoming you all. I wish you a very good discussion, and I will hand it over to Dr. Taha and Dr. Fathiya for further. Thank you.
Assalamu alaikum, everybody. Thank you very much for attending our session today. On behalf of SAP KSA, you're all more than welcome. And as Muhammad said, we are going to start our first webinar. There is a Q&A button at the bottom, if you could see. If you have any questions, please just use it. I'm a general pediatrician. I work in Johns Hopkins, Aramco Healthcare in Saudi. And my colleague, Dr. Fathiya, if you want to introduce yourself before we start.
Yes, thank you, Dr. Taha. I'm Dr. Fathiya, pediatric hemato-oncologist in King Fahd Medical City. Thank you.
Thank you. So our session today, as we all know, it's about one of the difficult challenges that we are having now in Sudan, lots of cases, as we know, of dengue fever. And we are interested mainly in the clinical approach and in pediatrics as much as we could. So we are very proud to have our speakers today. Dr.Yusri Taha. Dr.Yusri is well known. He's a consultant infectious disease and clinical virologist. He works in King Faisal Specialist Hospital in Riyadh, and he also works with the Royal Victoria Infirmary in Newcastle in the UK. He is an ex-lead of the high consequence and hemorrhagic fever unit in Newcastle in the UK. He has a PhD in molecular infectious disease. He is a fellow of the Royal College of Edinburgh and Royal College of Physicians, and he is also a fellow of the Royal College of Pathologists from London. He worked before as a consultant and director of the ID units for serious illnesses and viral disease, hemorrhagic diseases in Newcastle. He is an academic and had a very long history and lots of published papers in high reputed journals, and also contributed very well in research and some references. He's also ex director of the Research Center of King Abdullah International Center for Medical Research, and he was also previously the head of the medical safety program in the National Guards in the Eastern area. In addition, he had a very reputable and he has contributed very significantly in health education and voluntary work, medical training, and knowledge transfer. Dr. Yusri as well, he had good experience in capacity building in ID and epidemics that we had in Sudan before. That's our first speaker, and we are also very honored to have with us today our second speaker, Dr.Marcela Rodriquez. She's a MD and MPH. She's an associate professor of clinical pediatrics at South Illinois University School of Medicine, completed a fellowship in pediatric infectious disease at Washington University School of Medicine in St. Louis, and pediatric residency in Springfield, Illinois. She received medical degree from Libre University in Cali, Colombia. Dr. Rodriguez has a special interest in pediatrics antimicrobial stewardship, focusing on optimizing antibiotic use to improve patient outcomes and combat antimicrobial resistance in children. She is a pediatric antimicrobial stewardship medical director. She's a board certified in pediatrics and pediatric infectious disease, and is a fellow of the American Academy of Pediatrics, the Pediatric Infectious Disease Society, and the Infectious Disease Society of the United States. From the same institution also came Dr.Ezzeldin Saleh. He will be attending our meeting today, and he's going to contribute as well. Thank you, Dr. Ezzeldin. He's an associate professor of clinical pediatrics at South Illinois University. He earned his medical degree from University of Khartoum and pediatric residency at Penn State Hershey Medical Center in Hershey, Pennsylvania. Dr. Ezzeldin completed a fellowship in pediatric infectious disease at Duke University Medical Center in Durham, North Carolina. He has led efforts to improve screening and follow-up care for infants exposed to perinatal hepatitis C, and actively contributes to pediatric antimicrobial stewardship. He's an active member of the Pediatric Infectious Disease Society Global Health Committee. He also chairs the Antimicrobial Stewardship Working Group. He is board certified in both pediatrics and pediatric infectious disease. He is a fellow of Infectious Disease Society of America and Pediatric Infectious Disease Society. He has his long-term vision is to strengthen academic and research networks in infectious disease in Sudan, and to advance pediatric global health initiative. My God, this is very long. For every one of, as you could see from our speakers, has very long list of qualifications, and are, as you could see, well qualified to start to deliver this talk. With no further delay, I would let you enjoy the session. Dr. Yusri would start first. He will tell us about, he's going to introduce the talk, and he's going to talk about the pathogenesis and pathophysiology, tell us about the vector, the virus, and then he will hand to Dr. Marcela. The floor is yours, Dr. Yusri. Thank you.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. Thank you very much, Dr. Taha, Dr. Fathiya, and Dr. Muhammad. I am honored and really pleased to be a guest with the Sudanese Association of Pediatrics. I'm not a pediatrician, but as a virologist, I consider myself to be a pediatrician by proxy. And I'm also very pleased today and honored to have Dr. Rodriquez and Dr. Ezzeldin Saleh with me. And also hope this to be the first of many activities shared between the Sudanese Infectious Disease Association, SIDA, and the Sudanese Association of Pediatricians. So I'm just going to share my slides now. So we are going to talk today about dengue fever. We may have as well really chosen any other infection or any other mosquito to speak about today, given the many problems we have at the moment. So this is my first part. I'm going to talk about the bug, the mosquito, and the host. And I'm mentioning a few things about the pathogenesis and the virus. And then I will hand over to to Dr. Rodriquez to give us the main part of the talk, which is the clinical manifestations and the clinical approach to dengue fever, before I conclude with a few remarks about the prevention and control of dengue fever. So, viruses and vectors of viruses that have been restricted to certain areas have widely, as you know, spread across the world in recent years. And globalization and international trouble have specifically contributed to this spread, as it is global warming. The latter brought about, in one of extremes, drought and scarcity of drinking water that forced people to fetch and store water in conditions that are conducive to mosquito proliferation, and caused also, in the other extreme, floods that created habitats when water seeded for mosquito to multiply and reproduce out of control. And it is not just the movement of people at the time of peace, but also at time of war. Displaced populations, and we know that very well in Sudan, were forced to move to disease endemic areas and then to return home carrying possibly viruses with them and other infectious disease agents. We know that the wars in general and conflict throughout history have led to suffering and death of countless people. And, that happened through murder, through looting, through destruction, that were committed with impunity in the forms of terror against whoever you fight against, or as a reward for the victor, ghanima. Unfortunately, the warring parties, rapid support forces facilitated in many parts of the country widespread looting by allowing theft of transformers, cables, equipment, and they themselves demolished station buildings, power station, and engaged in systematic campaigns of destruction for the water infrastructure. And in addition to the main pumping stations of water and electricity, many thousands of wells distributed across various neighborhoods in the central region of the country and in the west were rendered unusable, and water pumps and cables were stolen. And without electricity and without water, the infrastructure of healthcare has suffered badly. And as you know, the healthcare infrastructure relies on these services. And of course, supplies and medicines that needed to prevent disease were also disrupted or diverted, and healthcare workers were either injured or moved away, or deliberately targeted or abducted, or even coerced into assisting with the war effort. And under all these circumstances, public health became a secondary issue that received really little attention, or it mainly became an afterthought to be dealt with after hostilities have ceased. And these are just pictures from various sources showing examples of outbreaks that occurred during the war in Sudan, including, either in the top left, a person lying down with a malaria, a hepatitis A outbreak, and many other vaccine preventable diseases, including measles here in this child on the left, bottom left, and cholera and diphtheria. And mentioning diphtheria, these are pictures courtesy of Professor Yusuf from Shindi, where he's seen tens and tens of patients with many deaths, even in adults, with diphtheria in the River Nile state, presumably, a state that is free from hostilities compared to other parts of the country. So dengue fever itself, that we're going to talk about today, is not a new disease or a new virus by any stretch of the imagination. It's been described by Chinese more than 2,000 years ago. Very succinct description of what we know that was indeed dengue fever. In the 17th century, there were big outbreaks that were very well described in literature in the area of Panama, and in the 18th century, there was big outbreaks in the plantations in the Caribbean. And this is where maybe the disease was given the name the broken bone disease, describing some of the features that Marcela is going to talk to you about later. In the 19th century, there was also a big outbreak in Eastern Africa, and maybe this is the place where the word dengue fever was first used and was translated to the Spanish, and from there it's used around the world. So people use the word, say, dengue or dengue or deng or danak, and I like the translation to Arabic as dank or danak. Since then, there were many documented outbreaks in North America, South America, Brazil, Peru, and from the 20th century, the virus began to spread around the world, but specifically into mainly seaports, and there were cases reported in Port Sudan in 1906, 1907. I will show you a clip or of a paper or a book that was written about these cases from Port Sudan more than 100 years ago. But it wasn't until around the Second World War, with the huge movement of troops in the South Pacific and Southeast Asia, when the dengue fever made a big spread around the world. And it was there when the virus was finally kind of isolated, discovered. The person who described the virus was the same person who developed the oral poliomyelitis vaccine, Sabin, a virologist from the US, and the US virologist and the Japanese, who were essentially looking after the soldiers who were involved in the war activities around the Second World War, were the people who were leading research in that aspect. Anyway, there used to be every 10 years, 20 years, there would be an outbreak, but that has gathered pace in recent years. 70 years ago, the virus was known to have occurred only in 9 countries. Now is reports of more than 100 countries, and the WHO estimates around more than 400 billion people to be at risk of dengue fever. This is the report I told you about from Dr. Andrew Balfour, who used to work in Khartoum. He used to work in the Wellcome Research Labs in Khartoum. And this is page 37 of a book that he contributed to. And he was disappointed because he wanted to do some research on dengue fever, and because there were some cases apparently in Egypt and in Halfa and in Port Sudan. So he came to Khartoum to study it, and he was disappointed because there were absolutely no cases, and he explains that maybe because there were no mosquitoes in the city at that time. That was 1908. So yeah, so we have known about the virus in our country for some time, but in the last 20 years there were more and more cases, and there are a lot of publications that describe various aspects of the epidemiology of the disease, and most of the studies came from the Eastern Sudan. This paper by the collaboration between the University of Khartoum, University of KSA, and the National Public Health Lab. Mawahib al-Digail and colleagues, Professor Tajuddin from KSA, have written about the outbreak in 2019, and proved that it was mainly genotype 3 virus that was causing the outbreak at that time. There were many other papers. This is another paper from Eastern Sudan. Mainly the patients were recruited from Port Sudan, showing genotype 4. There are other papers from other parts of Sudan, like Darfur. Ayman Ahmed and Yusuf Ali and colleagues describe that. And I could show you tens of papers, but I would like really to emphasize this important paper that is probably need to be updated now. This is written by Adil Hussein Al-Douma and colleagues, where they did a meta-analysis or systematic review of all papers that were published about dengue fever infection in Sudan. And they looked at 178 publications and whittled it down to only 19 to include in their meta-analysis and systematic review. And essentially, they showed that the virus is spread everywhere in the country. And this is 2020. This is 5 years ago. And I can tell you that most of the publications happened after 2020. And most of the problems actually happened after that. But in that review, the study highlighted the high burden of dengue fever in Sudan, up to 43%, and that is evidenced by serological surveys. And also, it showed rapid expansion of the dengue virus distribution in Sudan. So, we come now to the disease itself. This is what I call infernal triangle: the virus, the mosquito, and the host. And for an outbreak or even just a normal disease to happen, these three elements have to come together in time and space for the disease to occur. And of course, we know the dengue virus is, it occurs in serotypes. We've got 4 serotypes, 1, 2, 3, and 4, and they've got many other genotypes. And any one of these serotypes or genotypes can cause disease, either mild or severe. It doesn't matter. The type itself doesn't tell you what kind of disease one will get. The mosquito that is responsible for transmission of the virus from one person to another are the Aedes aegypti mosquito, and to some extent other members of the Aedes group, mainly the Albopictus, cousin of aegypti, and others that are maybe less important in contribution. And of course, the host, the person who's to be infected, is the infection depends on their immune status to dengue fever, and we will come to talk about that in a few minutes. So let's speak a little bit about the virus itself. The virus is roughly spherical. You can just look. It looks like this. Is an envelope virus. Is single-stranded. Positive sense. That means the RNA just behaves like an mRNA, and the size of it like 11 kilobases. And the genome itself here in the top hand corner there in the rectangle, you can see here there are 2 untranslated regions, the 3' end and the 5' end untranslated regions, and between them is this open reading frame in which the genome can be seen, that the proteases can split the polyprotein into 7 non-structural proteins and 3 structured proteins, the capsid and the pre-membrane and the envelope. And I just wanted you to just pay attention to the names that I'm going to mention here, because we're going to come back to it. So NS1, this non-structured protein 1, this is a very important protein in relation to 2 things. One is pathogenesis and how the disease happens and how the clinical manifestations occur. And also, because it's important in the diagnostics, we test for this abundant protein when we test for the virus. Also, the non-structural protein number 5, NS5, this is the RNA-dependent RNA polymerase. And if you are familiar with flaviviruses and other viruses, when it comes to antivirals, like hepatitis C, this is a type of the enzyme that we target when we produce antivirals. So NS5 is the polymerase enzyme, and NS2B is the serine protease enzyme. Again, with hepatitis C, with HIV, with Paxlovid in COVID. These are the type of the enzymes that are likely to be targeted in the drugs that are now in the pipelines. The pre-membrane M and envelope are important structural proteins. These are the proteins that are taken from this virus, type 1 or type 2 or type 3 or type 4, and then inserted into a chimera or a yellow fever backbone virus or a lab virus to produce vaccines for dengue fever, and we'll come back to that later. So this is what the virus does when it is injected into a human being through a bite from a mosquito. The virus comes from a person who is ill with viremia. The virus is taken by the mosquito, it multiplies in the mosquito, and then goes into saliva of the mosquito into the human being, and then it attaches itself to its receptor, and then it goes through releasing the mRNA or the positive sense RNA that is translated into genomic RNA and various bits and pieces that produce the particles of the virus that get assembled through the endoplasmic reticulum and then matures as a virion and then get released from the cell. The NS1 protein is also released from the cell as an abundant, as I said, protein that goes into the bloodstream. I want you just before I move from this slide to note this bit here where the virus particles can be complexed with antibodies that are already there in the body and then get internalized into the cell. So there is an antibody that can mediate or facilitate the uptake of cells of the virus. So just one word about the inflammatory responses of dengue virus. The dengue virus enter macrophage cells, okay? And that normally triggers a inflammation or inflammatory cascade. And the macrophage activation leads to the increase of the vasoactive factors that induce permeability and plasma leak. And this is the hallmark of pathogenesis of dengue fever, plasma leak. Also, the neutrophils are major effectors in the inflammation process, and they're recruited by the cytokines that were released by activated macrophages. So when we talk about disease in dengue fever, we mainly focusing on plasma leak and third spacing with fluid escaping the vascular system into other spaces. So now this slide is important, and I think Marcela will come back to something similar to this. So we've got an immune response to someone who is infected by a virus of certain type. We've got three options. Either the person has never had any prior infection, never been vaccinated, or the person has got strong immunity against that serotype that he's infected with, which is only left here, either from vaccination or from prior homotypic infection, so an infection by the same type. So if a person has never been infected before, never been vaccinated, he will have no antibodies against that type, and there will be no effective immunity against it, and there will be no antibody-dependent enhancement, the one that I showed you through that circle in the first graph. On the other hand, if a person is strongly immune against that serotype by vaccination or by previous infection, they will have neutralizing antibodies, and thereby they will have effective immunity and protection. The problem is in the middle, when the patient has a waning immunity against that serotype that is affected with this time from vaccination or from prior heterotypic infection. And this low level of antibody will bind the serotype, but it's not enough is not sufficient to neutralize it. And that what leads to antibody-dependent enhancement and facilitation of viral cell entry and replication, which will make things worse. And that will bring me to the last step about the pathogenesis, which is who is likely to have critical illness, who's likely to be ill. And the first one is what you just mentioned, a person who had an infection before, and this time is the second attack. And I hope I have explained to you how that happens. The other group that we fear critical illness in are babies, are infants who are less than 1 year old. And these are, they suffer through a similar mechanism. They will have a maternally derived antibody that is not enough to neutralize the invading virus, but also they are there and they may just facilitate viral entry and replication of the virus. The third group that we also worry about so much as far as critical illness is concerned are adults with comorbidities, significant comorbidities, people who are chronic renal failures, heart failures, respiratory problems, and these tend to do worse. And we've got anecdotal evidence now in the recent outbreak, or still unfolding in Sudan, that most of the death happened in this last group. Also from anecdotal evidence and correspondence with Professor Tajuddin in Kassala, last year, most of the people who got infected were people who were displaced, people who were new to the place there. And within those, the people who have less like socioeconomic power were affected disproportionately compared to others. So these groups, they tend to have the problem that we mentioned earlier, the plasma leak and the fever, and they will present with things like abdominal pain and vomiting and, lethargy and hypotension, tachycardia, wide pulse pressure. And I'm sure Dr. Marcela is going to take you through this, but these are the people who will come with these findings, either as symptoms or as signs, or when they are investigated, and they are the people who are more prone to have target organ disease and failure, whether it be a respiratory failure or renal failure, or even or myocarditis or CNS problems. I'm going to skip the laboratory diagnosis and leave that to Dr. Rodriquez to cover. All what I can say that we have different diagnostics, laboratory diagnostics in the early phase as compared to later phase of the disease. But in places like Sudan now, where the outbreak is ongoing, a lot of times we may not even need a laboratory diagnosis for dengue fever, and we use clinical criteria. So overall, we're not going to talk today, because it's out of scope of the talk, about vector control specifically, but this is an important thing, and we'll have to come back and mention a few words about it in part 3. So I'm going to be stopping sharing the slides now, and hand over to Marcela to take us through her presentation before we come back and just conclude with a few remarks. Thank you.
Thank you. That was great, Dr. Taha. So let me share my slides. Can you stop sharing yours so I can share mine?
Yeah.
Perfect, thank you. Let's try this. Can you see my slides now? Do you see the actual slides or the slides with the notes on the side?
We see the notes on the side, Marcela.
Okay, so let me just pick the other screen. What about now?
Perfect.
Okay, let me try to move them. Okay. Okay, well, thank you so much for having me. This is a pleasure, and I'm very happy to share what I know a little about dengue. I just have to disclose, I haven't seen a patient with dengue for over 20 years. Back home, I'm from South America, from Colombia, South America, and we had a lot of dengue when I was in med school. So at that time, long time ago, I was able to take care of these patients, not in the United States anymore, but of course, something that we're always watching for in travelers. And, it's very nice to review this topic again and catching up on stuff that I learned long time ago. So I'm going to talk mainly about the clinical insights and into diagnosis and management of dengue fever. So I don't have any disclosures. So a little bit about my outline. I'm going to talk about clinical manifestations, diagnosis, and management. So before 2009, the dengue classification was divided in three. It was dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. Then after 2009, the WHO came with this new dengue clinical classification, which is the one that we still follow, which is these three, which is dengue, dengue with warning signs, and severe dengue. So I'm going to go through each of them. So dengue is defined by a combination of two or more clinical findings in a febrile person who lives in or travel to a dengue endemic area. When I talk about travel, is in the last 14 days. And the clinical findings of these include nausea, vomiting, rash, aches and pains, a positive tourniquet test, and leukopenia. So moving to dengue with warning signs, these is a category that includes one or more of the following. Patient would have abdominal pain or tenderness, persistent vomiting, which is defined for more than 3 episodes in an hour or more than 4 in 6 hours, clinical fluid accumulation, patient would manifest with ascites, pleural effusion, mucosal bleeding, lethargy, restlessness, liver enlargement, and progressive increase in hematocrit. And lastly, severe dengue. This is defined by dengue with any of the following clinical manifestations. So severe plasma leakage leading to shock or fluid accumulation with respiratory distress, severe bleeding, severe organ involvement that would include liver failure, heart that can present as myocarditis, and lethargy, like that would present brain abnormalities with lethargy or seizures. So the clinical course starts with after an incubation period that is about 3 to 10 days. So after the incubation period, the illness often begins abruptly with fever and will follow 3 phases. So the febrile phase is something that lasts between 0 to 7 days. And something that I want to highlight is that a fever is the most common presenting sign in a person with dengue. Okay, this is the prevalent symptom. So following febrile phase, we have the critical phase. This happens after the effervescence, after the fever is gone, and this lasts between 1 to 2 days. Following this phase comes the recovery phase, which is about 3 to 5 days. So now going through each of the phases. So the febrile phase starts very abruptly. Patients would have a fever plus any of the following. Patients can have severe headache that can be retroorbital. They would have myalgias, arthralgias. They can have a transient maculopapular rash. They have minor hemorrhagic manifestations that can be petechiae, ecchymosis, epistaxis, hematuria. They can have a positive tourniquet test. They have facial flushing or erythema, injected oropharynx, and anorexia. So during this febrile phase can be biphasic sometimes. And as I said, it can last between 2 to 7 days. And monitoring for the effervescence and warning signs is crucial to identify progression into the critical phase. So there can be complications of the febrile phase, such as dehydration, hyponatremia, febrile seizures in young children, neurologic disease manifestations, including encephalitis and aseptic meningitis. So this slide, I just wanted to show the tourniquet test. That is something that we can do easily in the clinical setting. You inflate the blood pressure cuff to a point midway between systolic and diastolic blood pressure. You wait for 2 minutes, and then you measure in like a square inch how many petechia you have, and a positive tourniquet test is defined by greater than 10 petechia per 1 square inch. On the right-hand side, you see also the classic rash that patients with dengue would have. So lab findings of the febrile phase, throughout the whole illness, the labs are gonna change. So I'm just gonna go through each phase and how the labs will show. So during the febrile phase, patients would have some initially mild leukopenia. They have mild to moderate thrombocytopenia. This would get worse in a later stage. They have elevated AST and ALT. They can have low sodium, and they have sometimes normal or slightly increased hematocrit. So following the febrile phase, now we go to the critical phase. So after febrile phase, most patients improve and illness resolves. However, some patients progress to the critical phase that starts 1 to 2 days after the effervescence, and usually about 2 to 7 days after symptom onset. Typically begins around the time of the effervescence, but it might begin as early as the 3rd day after fever onset in patients who are still febrile. And this is the period when those who develop severe dengue will become critically ill. Most dengue patients will improve during the critical phase, and they will not develop manifestations of severe disease, and this is uncomplicated dengue, but some patients do not improve and report warning signs or worsening of their illness during the effervescence and need to be evaluated. So these warning signs are listed here. Those include clinical fluid accumulation that can show as ascites, pleural effusion, respiratory distress, hepatomegaly, severe abdominal pain, persistent vomiting, mucosal bleed, lethargy, or restlessness. So around the time of the effervescence, petechiae can appear, especially in lower extremities. And during this phase, there can be some medical complications, such as hypovolemic shock from plasma leakage, and organ damage, impairment due to prolonged shock, severe hemorrhage, and encephalopathy. So during this critical phase, there is going to be a rapid decline in platelet count with a rise in hematocrit, and there is going to be leukopenia. So this is the phase where the platelets are going to be the lowest and the hematocrit is going to be the highest. If patient improves and recovers the illness, this is classified as dengue with warning signs. However, if disease continues to advance, this is going to be classified as severe dengue, which is about 2 to 5% of cases. So severe dengue this happens in the critical phase and occurs in 5% of clinical apparent cases, and case fatality rate is 5%. So this is a significant illness that we have to detect early and we have to manage properly. And it has 3 different not classifications, 3 different status, like 3 different places where we were gonna see severe dengue. Basically, there is gonna be severe plasma leakage, and patients would manifest as shock and fluid accumulation with respiratory distress. There's gonna be severe organ involvement, including the liver. So you're gonna see increase in AST and ALT. There are gonna be organ involvement, including the brain. You have impaired consciousness, and the heart as well, so you can have myocardial dysfunction. And then severe bleeding also happens in this stage of severe dengue, where patients would have epistaxis, gum bleeding, hypermenorrhea, GI tract bleeding. So during shock, there is going to be rising hemoconcentration, rapid pulse, poor peripheral perfusion, and reduce of urine output. As I mentioned, severe dengue can result in death, and causes of death in dengue include the following. So unrecognized dengue without appropriate medical management, unrecognized or prolonged shock, unrecognized occult hemorrhage, fluid overload, nosocomial infections, and liver failure. So following the critical phase, then we go into the recovery phase that we call this also convalescent phase. In this phase, the patient shows improvement. There is a gradual reabsorption of extravasated fluid from the plasma leakage that happened before. This happens over 48 to 72 hours. There is increased diuresis. The hemodynamic status stabilizes, and then patient can temporarily become bradycardic, but is still hemodynamically stable. So there are medical complications also in the recovery phase of dengue, which include hypervolemia and acute pulmonary edema because of the intravenous fluid therapy that could have been excessive or extended too long. Organ impairment can result in the event of prolonged or refractory shock. So this might include ischemic hepatitis and hepatic encephalopathy, and also nosocomial or hospital-acquired infections can occur, especially in infants and elderly patients. So during the recovery phase, there is a second and convalescent rash that is described as macular or erythematous with small circular islands of normal unaffected skin. This rash can be pruritic and can desquamate, and it's also described as islands of white in a sea of red. And you see the pictures there. And also during the recovery phase, patient is going to be very fatigued. So these are the lab findings during this phase. So in this phase, when patient is recovering, so the hematocrit stabilizes, the white blood cell increases soon after the effervescence, and the platelet count starts also to increase following the white blood cell count recovery. So as far as outcomes, so dengue infection, actually the majority of patients, they get dengue and they're gonna be asymptomatic. Those count as like 6 to 80% of patients. Then 20 to 40% are gonna be symptomatic. Most of them, 95 to 99% are gonna be just dengue, but severe dengue happens in 1 to 5%, and of those 0.5 to 5% can die. Okay, so moving into diagnosis. So there's a lot of differential diagnosis for dengue fever, and I listed those there. So different viruses can mimic dengue, measles, enterovirus, adenovirus, influenza, arboviruses, West Nile virus. Bacteria can also mimic dengue, things like typhoid fever, leptospirosis, scarlet fever, meningococcemia, toxic shock, and even parasites such as malaria and Chagas. So moving into the actual part of diagnosis, so It depends on the clinical setting. Back home, when I was in Colombia, we just made a diagnosis of dengue clinically. You know, we couldn't, we didn't have the all the infrastructure and all the resources to actually diagnose by serologies or by PCR. So it was basically a clinical diagnosis. But if you have the infrastructure to actually be able to diagnose dengue through the microbiologic, part. So there are feral phase specimens and convalescent phase specimens. So what I mean by that is in the first 7 days or less after fever onset, this is the time where you can send blood and easily detect the virus by 3 methods. One is the dengue virus specific polymerase chain reaction, so dengue PCR. Second is the antigen immunoassay for the non-structural protein NS1, and IgM immunoassay is another one that we can order. So both IgM and PCR or NS1 are ordered to maximize chances of confirming the diagnosis when you have the possibility to order them. So moving to the convalescent phase specimens, so this is 5 days or more after fever onset. Here you have IgM immunoassay, and you have anti-dengue enzyme-linked immunosorbent assay for IgG. So this one remains elevated for life after infection, and fourfold or greater increase between acute and convalescent samples is indicated of recent infection. Something that I want to mention is that IgG antibodies, anti-dengue, they're cross-reactive with IgG from other flaviviruses. So such as West Nile virus, Japanese encephalitis, or immunization even with yellow fever vaccine or Japanese encephalitis can cause cross-reaction with this assay. And this can lead to false positive results. So in summary, so viremia and PCR positivity, they coincide with fever. An early serum specimen is required for diagnosis. If the first specimen is obtained late in the febrile phase of the illness, diagnosis might be more difficult since the dengue by PCR might not be detected. And in this case, a second convalescent specimen might be needed if the febrile phase results are negative. So IgM antibodies are detected for up to 3 months after infection, and IgG antibodies are detected for lifetime after infection. And as I mentioned, there is going to be some cross-reactivity with other flaviviruses. So at or shortly before the onset of fever and for about 5 days, dengue is present in the circulation and can be detected using molecular diagnostic, such as PCR. Also, NS1 antigen is detectable in serum, and you can order both, the PCR and NS1 antigen detection. But later in the febrile phase, that's when we start. We would need IgG to be ordered, because the PCR and most likely the NS1 are not going to be able to be detected. So this is a summary that, this is a slide that I like from the Pediatric Infectious Disease Society, where they summarize it in a graphic way. Just during the febrile phase, you get your PCR, the NS1 antigen, and you can get, the IgM, and later, when the patient effervesces in critical and convalescent, most likely you're gonna need the IgG to be ordered. So moving to management. So there are 3 dengue management groups, and they divided by places where you're gonna actually manage your patients. So group A is gonna be the patients that are the least sick, and they're gonna be the ones that you're gonna be able to manage, outpatient. So they must meet all of the following criteria. They should not have any warning signs. And just to remind everybody, warning signs include abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleeding, lethargy, restlessness, and liver enlargement. Those are the warning signs. So these patients treated in the outpatient setting should have no warning signs. They should be able to receive adequate volume of oral fluid. They should have a good urine output, and they should have a stable hematocrit, and they should be hemodynamically stable. Then you move to group B. These are the patients that are sicker. So they have warning signs, which I mentioned previously. These are the patients that have coexistent medical conditions. So they have diabetes, or this is a young infant, this is a pregnant woman, this is an elderly person, or they have renal failure, or they have challenging social circumstances. They cannot come back. They don't have, a close place to follow up. So these are the ones that you should admit and manage inpatient. And group C, these are the ones that have severe dengue. They are the sickest. So they must meet at least one of the following: severe plasma leakage with shock, fluid accumulation with respiratory distress, severe bleeding, hepatitis, impaired consciousness, heart impairment. So I think the most important part of treatment of dengue fever is fluid replacement. This is life-saving, and this should be doing cautiously. So we don't overload the patient. We don't take them to, heart failure. And this should be discontinued when the plasma leakage subsides to avoid iatrogenic fluid overload. One other important fact about treatment is avoid aspirin and NSAIDs. And then secondary prevention measures are key. So early identification and correct clinical management reduce fatality from 10% to 1%. So how we do identify plasma leakage in the clinical setting? So signs of leakage include ascites or pleural effusion as determined by examination or an imaging method, high albuminemia or hypoproteinemia, okay, hemoconcentration. So if the patient has a hematocrit more than 20% higher than the person's baseline, that's indicative of likely plasma leakage, or drop of more than 20% of baseline hematocrit following volume replacement. So here are some do's and don'ts for dengue management. So let's start with the don'ts. So don't use corticosteroid routinely. Don't give prophylactic platelet transfusion or for a low platelet count. Don't give half normal saline. It leaks into third spaces. And don't assume always IV fluids are necessary. So first, check the patient. If the patient can take fluids orally, that's ideal. And use only the minimum amount of IV fluid to keep the patient well perfused. And decrease the IV fluid rate as hemodynamic status improves or urine output increases. Then what should we do? So tell your patients when to return. Okay, teach them about warning signs, abdominal pain, vomiting. We should be, as clinicians, able to recognize the critical phase of the disease, do closely monitor for fluid intake and output, eyes and nose, vital signs, and hematocrit levels. We should be able to recognize and treat early shock. We can administer colloids such as albumin for refractory shock, and we can give packed red blood cells or whole blood for clinically significant bleeding. So for outpatient management, we should tell our patients about fever control, prevent dehydration, prevent spread of dengue within your house, right? Of course, it could be complicated in some settings, but you should try to keep the patient with dengue, isolated, mosquito control at home, so we just prevent, more transmission. And we have to tell them, watch them for warning signs. And then in the inpatient setting, frequent vital signs and hemodynamic assessments are necessary. Detailed fluid balance, eyes and nose, very close and organ function monitoring, so liver function test, renal acid-base balance, hematocrit monitoring. IV fluid should be isotonic or colloid for refractory shock, and monitor signs of hemorrhage. So I think I'm gonna stop here.
Very good. Thank you very much, Marcela. Really appreciate it. And I think it was really clear.
Thank
You want to add
you.
anything, Dr. Yusri?
Thank you very much, Marcela. That is fantastic. Thank you so much.
My pleasure. Thank you for having me.
So shall I carry on, Taha, just to then we can have time for questions and answers.
Yeah, of course, yeah.
Yeah. So okay. So this is the last section, just about a few words about prevention. So whom do we target by prevention of this is the triangle that we spoke about, the virus and the mosquito and the host. So whom do we target with prevention? Everyone. So we've got no specific group that we think we should omit or say there's no problem. You know, with COVID, for example, at the beginning of the pandemic, we thought children are not badly affected by the virus, so they were not targeted specifically. With dengue fever, everyone. There are groups that are more at risk, as Marcela said, a pregnant woman, a comorbid person, an infant. However, everybody else should be protected as much as possible from dengue fever. Where everywhere, especially the tropics and subtropics, and places where endemicity is known, and when in fact throughout the year there are seasons, sometimes heightened seasons for dengue fever. However, in places where the infection has not been endemic for a long time, the transmission can occur throughout the year, and protection will be required throughout the year. So, as we said, the transmission occurs when a susceptible host and the virus and the mosquito, a mosquito that's capable of transmitting the virus, co-locate in time and a place, found in the same place. So in order to prevent infection, we have to break one side of this triangle. And the weakest link is really the mosquito, because we can do nothing about the host, really. The interventions that are related to socioeconomics and things are difficult to use as a preventative measure for an outbreak, or for that matter, for long-term prevention. The virus itself is difficult to control because it is found only in the bloodstream of a febrile patient. That's it. So you cannot, it's not like other respiratory viruses where you can say, I'm going to wash my hands, or I'm going to use a alcohol gel, or it's not like a GI or where you can wash your hands or improve hygiene. This is only in the blood of the host. So we could do really little about the virus itself, but we'll come to that. So the weakest link is really the vector, and in particular, I'm not going to go into details about this, but in particular, indoor spraying. That is targeted indoor spraying to target the flying phase of or form of the mosquito. Looking at where the mosquito rest, under furniture, under the tables, inside the cupboards, inside shoes, and most of the indoor spraying is sometimes done by the authorities rather than by the individuals. However, we have to target the other phase of the vector, specifically the water phases, and reducing breeding sites is possibly the area that the community as a whole has to participate in so massively now, and to continue doing that for maybe years to come, because we are not targeting only the forms that have not hatched, but also the egg. And the egg of the mosquito are hard, and they can stay viable for the whole year until the next season when the rain comes. Then it can hatch, and new mosquito will fly again and start a new life cycle. So it's very important that we all engage in reducing the breeding size by drying out and taking all whether these containers are azyar or baramil or jirkanat or anything, they have to be cleaned, and the cleaning has to be done on regular basis, twice a week, for weeks and weeks to come. And we're not talking about just this outbreak or this year. This is something that we have to do in a sustained manner for the next few years if we are to get out of this. And there are other measures to control mosquitoes that are divergent from the normal ones that we ought to do every year, like larva control using pots. This is being tried in Southeast Asia, in Vietnam, but it's not suitable for urban context. Let's just move on about how to break the transmission between a mosquito that is already been infected and flying and the host. This is normally through using personal protective measures. We know the mosquito bites during the day mostly, or in the twilight, very early hours of the day or late hours of the day. And if somebody takes sleep by daytime, qaylul or so, they have to be as much as possible and namusiya. And also if you're going out and about during the day, long sleeves and as little as possible of your skin being exposed, and use the repellents, creams, DEET based type of creams. Of course, it is just difficult to do that, but people have to try as much as possible. If you are inside the house and the house is very well screened, or there are air conditioned, for example, that normally will reduce the risk of exposure to mosquitoes. The other part that we have to focus on, or we can focus on, is or can we sterilize, can we vaccinate the mosquito from getting the virus? Is that possible? Well, the barrier that Dr. Rodriquez already mentioned, if somebody is febrile, that is the time when they are viremic. This is the time when a mosquito that is feeding from their blood can take the virus from them and give it to another person. And that febrile person have to be really hidden away from the mosquito to stop it from being infected with the virus. Then we can prevent it transmitting it to a third person. So that is what we call barrier. However, there is also some innovative way of sterilizing the mosquito by infecting it with a bacteria called the Wolbachia, or this is an obligate intracellular bacteria that if mosquitoes are infected with it, that will reduce their susceptibility to be infected with the virus, and thereby, even if they feed on an infected person, they will fail to transmit the virus to another person. And I'm going to show you a paper about that. The other or the third part of the triangle is the stopping the virus from replicating in the host, in the human. And that could be done by vaccination, of which we have 2 vaccines that I'm going to tell you very briefly about, or antivirus, giving the person an antiviral that can block the replication of the virus within them and treat them. So Wolbachia, this approach is called endosymbiotic control. So you infect the mosquito with a bacteria and breed it in big numbers, and then release it in a locality, and then it will kind of breed with the wild type mosquito. And as I said, this mosquito is incapable or less susceptible to being infected with the virus. This study, which was done in Indonesia, I think, where 24 clusters were randomly assigned to receive release of Wolbachia-infected Aedes aegypti, and other half did not receive. They just have their normal mosquito. And the researchers followed 8,000 participants aged between 3 and 45 who had acute undifferentiated fever for the duration of the study, which was 2 years. And they found that dengue fever caused 2.3% of the fevers in that group when in the areas where the Wolbachia infected mosquito was released, while in areas where there's no intervention, the controls, 9.4% of the fevers were caused by dengue fever. So the efficacy for the protection against infection in general was 77.1%, with a good 95% confidence interval. And the efficacy for protection against hospitalization, meaning protection against severe disease, was 86.2%. So you could see that the numbers are as good as any vaccination given to the human being. This is kind of vaccinating the mosquito. This study was replicated in other places, including recently in Brazil, and still the WHO have not fully endorsed this measure, waiting for more evidence, and I think it's going to be a little bit difficult to do, but it sounds like very, very good and promising measure to control the vectors. Last point is about the vaccine development. I'm just going to repeat few concepts that I've already mentioned maybe. Number one, infection with any serotype of dengue fever confers long-lasting protection against that same type. It would not protect you against other types, except for a short duration. And also there is an association between previous exposure to dengue types and severe disease, as we mentioned. Number three, all 4 types of dengue fever are capable of causing severe disease. There's no one that is better than the other. And the last point I have to repeat is waning immunity might also increase the risk of severe disease. So having known these 4 facts, for an ideal dengue virus vaccine to be produced, the vaccine should produce protective immunity against all 4 types. So essentially a tetravalent immunity. Second thing is that the vaccine-induced immunity should be long-lived. It shouldn't be like waning in 2 months or 1 year or something, because that will predispose the patient to problems if it becomes low level or short-lived immunity. With these criteria, we have 2 dengue virus vaccines available at the moment. One is called Dengvaxia and one called Qdenga. So just 1 word, 2 words about the Dengvaxia. This is approved after large 3 controlled trials. It's like given in 3 doses, and the backbone of the vaccine is a yellow fever virus. So it's a chimera, as I mentioned earlier in the first talk, and the efficacy is up to 61% against virologically confirmed dengue fever. But the efficacy against hospitalization is excellent, or dengue hemorrhagic fever, up to 95%. There is variability, though, according to the serotype. So not all types are covered in the same way. And the coverage also, the efficacy against children who are 2 years to 5-year-old is less than in adults. However, the risk of severe disease and hospitalization was found to be more in individuals who were seronegative at the time of vaccination. And this fact was uncovered like 3-4 years after the vaccine was licensed, which made a lot of bad publicity. So now, as part of the license of the drug, of the vaccine, a person has to be tested first. If they're seropositive, they can be given the vaccine. If they're seronegative, they're not given the vaccine. That is part of it. But unfortunately, although this vaccine is licensed in many, many countries, maybe more than 20 countries around the world, it will be withdrawn in 2026, mainly because of lack of market. So nobody's buying it. So the company that is producing it is going to stop producing it from next year, unfortunately. The second one, the Qdenga, also approved after clinical trials, one in Asia and one done in the Americas, is licensed for children who are 4 years and older and adults, and it protects seropositive individuals against all dengue fever and hospitalization, up to 90% efficacy. And it also protects seronegative patients, but only if they are only against genotype or serotype 1 and 2. Serotype 3 is not very good. It doesn't protect very well, and the data so far is not very conclusive for serotype 4. So these are the two vaccines that are there. Essentially, we've got only one vaccine remain. However, there are so many other candidates that are now in the pipeline. So in your left-hand side here is the live attenuated viruses. I've mentioned 2 of them. The third one is the butatan, is nearly there. And then there are other ones, including an mRNA vaccine that is almost there. So I think from the ongoing now outbreaks around the world, spreading everywhere, vaccination is going to be very important to get humanity out of this. Yes, vector control can work to some extent, but the vaccine is probably going to be required if we are to control this disease that is now surpassing many of the more established infectious diseases around the world. So I will stop here, and I'm happy, and I'm sure Marcela and Ezzeldin to have any discussions. Thank you very much for listening.
Thank you very much, Dr. Yusri and Marcela. Before we start the questions, I don't know if Dr. Ezzeldin would like to add anything.
Thank you very much. Yeah, thank you, Yusri and Dr. Rodriguez, for the excellent presentation. I think they hit all the good points. The main thing is just for our pediatricians in Sudan to keep in mind that dengue symptoms overlap with a lot of other infections, and UAC malaria and other typhoid, other clinical diagnosis similar to dengue. So, but given now the outbreak and the spread of the infection all over Sudan, we have just to keep dengue in our differential diagnosis with all children presenting with febrile illnesses. And if you don't think of the diagnosis, then you will miss it. So you have to keep that in mind all the time. And again, we have the restrictions as Dr. Rodriguez had in Colombia. We don't have a lot of diagnostics available in our hands, so we have to use our clinical, assessment, and CDC, WHO. They have also a lot of guidelines, and I'm sure you will see the recording of this lecture. Also use it to your benefit and try to evaluate patients and apply the management. And this disease has been there for a long time, and a lot of other countries have been managing dengue for a while. So try to be steward when you treat patients, and don't overuse. No antibiotic needed. Again, platelet transfusion is needed only if there is continuous bleeding. So just follow the guidelines, and that's the best. And we'll talk more about the questions as we guys handle. Thank you.
Thank you very much, Dr. Ezzeldin. I think we should start the questions and answers for people who are attending. It's well attended. Thank you very much. Please put your questions in the Q&A session. We'll start with the first question. Dr. Fathiya.
Yes, thank you, Dr. Taha. The first question is about the presentation of the dengue fever in neonates and indications of admissions.
Yes, thank you for that question. So neonates are, I would say tricky because they won't have kind of like, they will have very non-specific presentations. They would have, I think for sure they would come with fever, they would come with maybe poor feeding, the rash, lethargy, but you have to have a high index of suspicion in a neonate to think about, dengue. they are going to be more prone to get severe disease. So that's why you have to be alert on a neonate. And what I was reading is that neonates can have dengue through two mechanisms. One, they get it vertically, right? They get it from mom. And the second one, they got it after birth, postnatally through the mosquito regular route. So I would say non-specific symptoms, fever, lethargy, decrease of oral intake, rash, poor feeding again, and just have a low threshold to maybe, if you're suspecting dengue, maybe to have them, in the hospital, like kind of like to, watch them closely if possible.
Great, thank you. Another question regarding role of frequent CBC follow-up. Do I need to do like routine CBC or just symptomatic if the patient start to develop bleeding? So I need to send CBC to check for the platelets count.
Yes, I saw that question. I would say if the patient is not is ambulatory and doesn't have any warning signs, I don't think you need to do any CBCs if there is no suspicion of warning signs of critical illness. I think the regular hydration, fever management, and all that. But I don't think if they're managed outpatient and they're not sick enough, you would need to do serial CBCs. And please,
agree.
if somebody has different opinions, please jump in.
No, Marcela, I agree fully with that. Specifically not for platelets. I know people are focusing on platelets specifically, but hemoglobin is really as important or more important especially if there is bleeding. And we don't normally do anything for platelets unless there is bleeding and the readings are low. So I fully agree with you. There is no indication for regular follow-up. The hematocrit is different. So I might do the repeat the blood counts just to see in somebody who is admitted to see how he's responding to treatment and use that as a guide.
Great. So another question for transfusions, for example, does blood transfusion is superior to platelet transfusion in case of bleeding?
What I found is that we should not give platelets for low platelet count. That yes, blood it's better than platelets. And what I read is that giving platelets can cause a fluid overload and prolonged hospitalization. So and bleeding is not only due to low platelets. Bleeding is due for capillary fragility and coagulopathy, not just low platelets. So I don't think platelets should be our first way to go for like fluid replenishment.
Absolutely. Thank you very much for making that very clear. There is, Marcela, maybe you don't know, but we've got a practice of transfusing platelets, and there are no guidelines that supports transfusion of platelets. And as you said, it may just make things worse. The reduction in platelets is part of the pathogenesis of the disease, and normally it normalizes as soon as the person improves, and sometimes it improves quite dramatically and go back to normal. So if there is somebody bleeding, person needs to be resuscitated, blood transfusion is the way to go. But platelets on its own has no place in the management of dengue fever or severe dengue.
Dr. Yusri, I just sorry to interrupt the Q&A session, but talking about the practice and what's in the media, can you just give advice about the practice of giving IV paracetamol? It has been widely used now, and it went to crisis because people they just love the paracetamol. So when can we use the IV paracetamol if we need to?
Yes. Well, I mean, paracetamol is not given to treat the virus. Paracetamol is given to relieve the symptoms. If a person is febrile or having, the pains, the muscle pain and the, joint pains and the headache are a big part of the syndrome. So we give paracetamol to relieve these symptoms. If a person can take paracetamol orally, why would he take it intravenously, or she? Why would they take it intravenously? We have to make that very clear. So there's no superiority for the intravenous route over oral route, except for a person who cannot keep his intake down, or he's vomiting continuously. Then intravenous paracetamol will be indicated. Otherwise, it's just a waste of resources that we don't have much of anyway.
Thank you very much for making it very clear. No need to give IV paracetamol if they can, unless they need paracetamol orally. They can take orally if they need it. Otherwise, if they're vomiting or there's contraindication or problem with giving it orally, then you use the IV. Thank you very much, Dr. Yusri.
Thank you so much also, Dr. Taha. So my last question, and then we will switch to Dr. Taha to moderate. Our dear Professor Haidar Babakir, he has a question regarding coexistence of CNS manifestations in children with dengue fever. So, and cases of meningoencephalitis as well. Any comment from experts regarding management and interventions?
I can jump in very quick, if you don't mind. Yeah, so I think I saw the question earlier, and I was just reviewing the literature to see what there. So there is several systematic reviews, and most of them they found definitely it is reported you can have encephalitis or meningitis, but when they reviewed the literature review, the systematic reviews found that confirmed cases, about maybe 34% of the cases reported in the literature. So a lot of them, they go by symptoms, but you have to have confirmed cases with the CSF PCR. But definitely CNS disease occur, but it's not very common. In some of the theories, they report about in Thailand, for example, they have 5.4% of children had neurological manifestations. In another study also in Brazil, they found about 39% have neurological complications also. But again, confirmed cases are not high, so around 5% or so. In another Brazilian study, they have, again, they presented with meningitis, bulging fontanelle, motor complications, encephalitis. So you have to keep eye on that. And there is also post-infectious immune syndromes reported, Guillain-Barré and acute demyelinating encephalomyelitis. So that's also reported. And again, also in some cases, they can have CNS disease without neurological presentation. So you can have positive CSF PCR with classic dengue. Yeah.
Thank you very much. Okay, just I will keep on the Q&A. There's a question here about co-infection with malaria. This is different. The vector is different, so the mosquito is different. I don't know. I'm not a virologist, or microbiologist. But different vectors just to get the two infections. Is it because probably just reduce the immunity, or just it's unlucky?
Because they've been bitten by two mosquitoes, most likely, and that as simple as that. I mean, I have to mention something about the habits, the biting habits of the Aedes mosquito. It is quite interruptible, so it bites very quickly and flies away. Maybe because it's biting during the day, of course, and it cannot afford to dwell on taking a meal. So it has to really come and take a small meal and just straight away flies away. And because of that, it wouldn't have taken enough meal to form the eggs that it needs to lay. It will have to go for more than 1 or 3 or 4 people to bite before it can complete its meal. And that's why it can actually, one mosquito can spread the disease to more than one person in one cycle of his life. So, but it is a completely different mosquito as opposed to the malaria vector. But unfortunately, when it comes to the rainy season, to the conditions conducive, the habitats, they are similar. And when we have high numbers of mosquitoes, of Anopheles, we will have also of the Aedes. By the way, now in Khartoum, there are also Culex, which is the another mosquito that is known to transmit other infections like yellow fever or West Nile encephalitis, and is a big worry, because if for any reason one of these viruses get introduced, we've got the vector that is capable of transmitting it between people. And that is another point, Taha, about people have to focus on all sorts of vector control measures to control all the diseases at once, rather than focus on one rather than the other.
Thank you, Dr. Yusri.
Actually, if you allow me, Dr. Taha, at this point, what do you think about the practice of giving IV quinine for a very sick patient with fever and thrombocytopenia, to give him a benefits of doubts of severe malaria versus dengue fever, especially in remote areas where there are not available labs and serologies, PCRs?
You mean without diagnosis?
Yeah, if I have very sick patient, febrile, with thrombocytopenia, I cannot have an access for any diagnostic tools. Could I try IV quinine,
I
for example?
think you do what you would have normally done. If you and nowadays, the only test that we kind of insist on is the malaria test. So if you've got someone now with a febrile undifferentiated fever in the Sudan now, you do the test for malaria. If you find, so even if if the symptoms were classic for dengue fever, a headache and pain behind the eyes and muscle pain, and you still have to do the malaria test. And if the malaria is there, you say, okay, this is malaria plus dengue. If the malaria is not there, then you can say this is dengue. You will have to treat malaria if you suspect malaria and you cannot diagnose it, because malaria kills.
Okay.
Yeah, the mic is yours, Dr. Taha.
Okay. There is a question about the post-dengue fever prolonged fatigue. Does it cause chronic fatigue syndrome, Dr. Marcela?
No, I have to be honest, I haven't looked that one up. I know they have fatigue for a long time, but I don't know if it's like, like how we now have prolonged COVID, and that's actually a defined entity, but on prolonged fatigue secondary to dengue, I'm gonna have to look that up.
Yeah, I think
I'm looking at it
Marcela,
right now.
yeah, I think it's the way it was described is like after a person recovers completely, the fever is gone, the third spacing has reabsorbed, their counts are better, but they just remain tired and fatigued, and that could be for long weeks. And it just says that, it says for long weeks, 4 weeks, 5 weeks, 6 weeks, before they gradually return back to normal. But it's not described like the long COVID that we know now as an entity, and it's not as the fatigue that we've seen in Lyme's disease or anything like that. So it's just longer than usual, but ultimately the person will have recovered otherwise, and it just takes time before it improves.
Yes, thank you.
Any strategies you could do, anything to do to help with this fatigue?
I am not aware of anything specific like the measure that we use for long COVID or chronic fatigue syndrome. No, I'm not aware of anything like that.
Okay. Thank you, Dr. Marcela and Dr. Yusri. Next question is about the cardiac enzymes. or arrhythmias? Like, does it cause arrhythmias or, like carditis, myocarditis, pericarditis, any?
Well,
Marcela? Yeah.
I would
Marcela?
say yes. I mean, patient would have myocarditis. And I'm just finding here on some studies, one from 2010, that 54% of patients with dengue can have elevated troponins. 36% can have EKG echo abnormalities. So in actually children with dengue shock, elevated CKMB could be in 62% of patients. So yes, that's something that can happen. I would say, like, if the patient has cardiac manifestations like heart failure, or your echocardiogram shows abnormalities, decrease in ejection fraction, I think yes, you would have to follow the cardiac enzymes.
Thank you very much. Two questions about management. Any role for antivirals?
And I didn't find anything about antivirals at this point for dengue fever.
They tried, Marcela, to repurpose some of the antivirals that were used for other viruses, but the results were all blank. So none have worked so far.
Mm-hmm.
And what about steroids?
I found no. There is no evidence behind using steroids in dengue.
Thank you very much. And this question is addressed to you, Dr. Yusri. After thanking, question about vertical transmission. I think Dr. Marcela earlier mentioned that this is one of the types of transmission. So yes, there is vertical transmission. And the question is, when the risk will be higher during pregnancy, is there any particular time during pregnancy, and what's the expected course of the baby? I think they probably mean the mode of delivery and any specific, because this is a consultant for neonatologist, Dr. Muhammad, he's asking this question, as you could see. So
yeah,
yeah,
there definitely can be vertical transmission from mom, and I was reading that usually it is within 10 days before or after birth that it kind of like that's the time frame from when a mom that has dengue can transmit to the baby, because the virus crosses the placenta. So yes, it can happen, and it's within 10 days.
So Marcela, this is related also to the fact that the mother herself did not have antibodies. When the infection happens early in pregnancy, the antibody from her, the IgG, can pass down the placenta and can have some kind of neutralization or positive impact. However, if the baby is infected in the last 10 days of pregnancy, then there will be no time to pass the antibody from the mother, and that's how it happens.
One question again about the thrombocytopenia, and the question is about any certain platelets. Is it, like, the question is if it's below 20,
no bleeding,
no
bleeding, no treatment.
No bleeding. Yeah, no treatment. Exactly.
Absolutely,
you go clinical, I think.
Yeah. So if it is less than 20, still you can just, when it becomes less than 20, you can argue that you won't watch it, especially in somebody who's got other manifestations of severe disease. However, it is not an indication for transfusion.
Intracranial bleeding, Dr. Yusri, would you not be worried about that?
No, not with a platelet of 18 in an otherwise normal person. No. If they are bleeding, that is different. But a platelet count of 18 or even 12 or 10, and a person is perfectly fine, I would not expect them to suddenly drop and bleed inside the brain because of that. And as Dr. Marcela said earlier, it's not thrombocytopenia on its own. Bleeding doesn't happen because of that. It is just one factor out of many other factors that happen in severe dengue.
And the next question is still about management. Somebody asked about dexamethasone. You know, people say, I mean, I heard this like in Europe a lot, no patient should die before receiving steroids. So in very critical patient, would you know, if you feel the patient is dying, would you try it? I probably say yes. I don't know. What's your answer?
I will definitely, hesitate a lot about doing this. Number one, we know that it hasn't got an antiviral effect. However, if somebody's got sepsis, and Dr. Rodriquez has mentioned that before, bacterial sepsis can happen. If you've got an indication for it from intensive care viewpoint to give steroids, that is different, but not specifically to treat severe dengue virus. And we know the way the pathogenesis work is not like COVID, where you could still think steroids can work. This one, it was tried and it did not work. So in normal circumstances, you wouldn't do that.
Okay. Last question before I hand back to Dr. Fathia. If baby born with 10 days, what treatment will with platelet or just conserve it? I think you answered this question early on, that your treatment is conservative. Indication for neonates, that was answered early on. Just with fever, without warning sign and sepsis excluded clinically, I would say you go clinical as said early on. Yeah. Dr. Amal is asking, up to in Port Sudan, infants and children around puberty up to early 20s develop severe disease. It's not that infants and children around up to puberty. So these are all the children, like from infants to puberty to early 20s develop severe disease. Is that like a high risk group or what? I don't know. I mean, is that, you know?
I mean, as we said, Taha, severe infection can happen in anyone. It can happen in anyone. There is no age group where we can say it doesn't happen at all. It can happen in anyone, but there are ones who are more risky than others. So an adult with comorbidities, somebody who is on chronic hemodialysis, or somebody who's got a heart failure, or then these people are more at risk of complications. But severe disease, especially if it's a second attack, it can happen in anyone of any age. It's just the nature of the bug.
Okay, Dr. Fathia.
Thank you, Dr. Taha. Yeah, we have a question from our Professor Sati Abdulrahim. He's asking that does this mosquito bite at night also, and how this is common or none at all?
Well, I mean, we have asked the entomologist. There's nothing like it will never bite at night, but the vast volume of the biting activity happens during the daytime and the twilight. So the first hour or two of the day and the last hour or two of the day. مع المغرب قبل طلوع الشمس مع طلوع الشمس. These are the time when it is at its active nature, and it goes around to find persons to feed on, to make its eggs. Would it bite at night as well? I don't know. It may do that, but it will be less of like significant than the volume of biting that happens traditionally during the day and the twilight hours. We don't know. I mean, there are people who believe that the urban life now and the lights and things like that may actually change a little bit of behavior of the mosquito, and even the viruses, the mosquito that are infected with the virus tend to behave differently from the mosquito that are not infected with the virus. So there are a few things that we still do not know, but in general, it is a daytime biter as opposed to the malaria one that bites normally in the night.
Great. So another question from our dear Dr. Yusuf Mukhtar. What is the role of IVIG in management of dengue thrombocytopenia, or in other words, post dengue ITP?
Yes. So overall, in general, IVIG, what I found is that should not be used for dengue-related thrombocytopenia because it's multifactorial. Is usually not indicated. If there is ITP after dengue, then it could be used for that. But overall, in general, for dengue-associated thrombocytopenia, I didn't find that as a management recommendation.
Fantastic. Thank you, Dr. Marcela. So I think the question regarding specific tests for diagnosis already have been answered through the lecture, IgG, IgM, and PCRs. And then also this one, I think also already answered about the second time infection by other serotype. Is it more complicated than first exposure to the infection?
Yeah, I mean that's true. We have answered that question, but I think somebody asked a slightly different question, asking about whether one infection will protect against the other types, and it does. So if I'm infected with type 1, I get protection against type 2 and 3, but only for a limited period of time, maybe the first 6 months, the first year. After that, I will remain immune to the original serotype that I was infected with, but the immunity towards the others will wane off over the time and disappear.
Great. Actually, I have a question regarding giving a prophylactic albumin transfusion for special patients like patients with comorbidities before developing the dengue shock, for example. Is it working or not?
I didn't find that in my reading about prophylactic albumin.
Certainly not prophylactic, no.
Great. So, any other comments? I think we can.
Dr. Amal, actually, she just corrected that. She meant severe infection in Port Sudan. They noticed that it occurs in children around puberty. She just, is it hormonal or any, just any other like thoughts about it? Is it just the hormones in this age or some ideas?
I don't know. I have no idea. And these are the studies that we do not maybe have fully now. There were, as I said, very good studies from KSA and other places in the last few years, and our clinicians have tried to delineate age groups and other variables, but adolescents or children at puberty age having more severe disease than others, I would definitely need to see that data and see is it just chance or is it a real signal?
Great. So, ladies and gentlemen, as we come to the close of today's webinar, I would like to extend our heartfelt thanks to all of our speakers for sharing their valuable expertise and insights, and to every participant for your active engagement and thoughtful questions. Thank you so much. Thank you, Dr. Yusri, Dr. Marcela, Dr. Ezzeldin, Dr. Taha, and all, Dr. Muhammad, and SAP KSA. Thank you so much.
Before we leave, just one thing about the feedback. Please, before you leave, you'll get a feedback form online, like before you leave. We value your feedback and your suggestions. So please let us know what you thought about this and what we can do in future. Appreciate it. Mohammed, you want to say something?
Thank you very much, Dr. Taha and Dr. Fathia, the academic office. This was a very informative and very fruitful presentation about dengue fever. We thank our speakers from USA and Dr. Yusri for organizing such a good group for discussion. And we hope to see you forward in another commitments and another important topics. Certainly, we don't want to be this one is the last one, but we say this is the first one. Thank you very much, and I wish you a good night. And
Thank you.
Thank you. Thank you very much.